They don't address the need for supportive services like childcare and transportation. They don't address employment barriers like mental or physical health problems. And critically, they don't reflect that many Medicaid and SNAP recipients already need work, but don't earn enough to meet their basic needs. So a few of the different things we'll be discussing. This is all of the different barriers to coverage that we might see implemented in some areas, but today we'll be discussing work requirements, cost sharing, and drug testing, lifetime limits, requiring payments to HSAs, and more frequent redeterminations are things that I would definitely encourage you to do some research on as well. So work requirements currently apply to federally funded cash, food, and housing programs. The function of a work requirement is to impose sanctions on benefits, to create regulations or requirements that can lower the limit or lower the spending of safety net programs through bureaucratic requirements. They have not yet been applied to Medicaid, although there have been a few waivers and applications for a similar process. States like Arizona, Maine, Kentucky, Iowa, Indiana, and Wisconsin are all considering them. Kaiser research shows that 59% of all expansion populations recipients are working with the majority of others either in school or caring for a disabled family member. So that wouldn't qualify them for the work requirements, but it would certainly be a barrier. These barriers are often ineffective and unnecessary, but they would be truly magnified in a healthcare application if you think about the different complications of and needs for healthcare that lead someone to be unable to work. So as we've done in the past couple of weeks, it's important to understand the arguments for and the arguments against, or the two different sides of this development that we're going to be hearing in the coming weeks and months. Proponents for work requirements argue that they incentivize work, that when people have living wage jobs, they're then able to move out of poverty, and it decreases dependence on the social safety net. So again, as they develop living wage earnings, they're able to move off of the social safety net. People who argue against work requirements say that it increases the number of uninsured, or as we said in other examples, increases the number of people unable to access SNAP or other social safety net programs. And this increase in the number of uninsured leads to increased out-of-pocket and emergency room health costs. It also increases administrative costs for the federal and state governments to have to go through this sort of paperwork and the bureaucracy of determining whether or not someone is actively working or looking for work. But people are less likely to be able to work if they have unresolved healthcare concerns or untreated illness. So you can imagine that cycle of needing treatment for care, or needing treatment for an illness or a substance use disorder or some sort of complication from any health concern, and being required to work before you can get the coverage necessary, and causing that cycle of not being able to work until you can get the treatment you require, and it's going to go on and on and on. In food stamps in 2015, 42 states had partial or full waivers of work requirements for able-bodied adults who weren't raising children. Frequently you'd hear the term ABOD, able-bodied working adults. These waivers were implemented after the Great Recession, and so many states were able to issue SNAP benefits to single adults, families, without any type of work requirement in place. In 2016, though, many states returned to a 3-month time limit on those SNAP or food stamp benefits, and effectively sent their waivers back to the federal government. This took 500,000 to 1 million people off of benefits in April of 2016. It affected unemployed adults 18 to 49 who aren't disabled or raising minor children. And in some states, as many as 75% of people who were receiving food stamps lost their benefits. These waivers were made to accommodate high unemployment and need. And that unemployment and need, while it may have reduced after the recession, doesn't go away for the individuals who are receiving the program. So the effective work requirements on any safety net program, we know across the board that the most vulnerable are going to bear the heaviest burden. So people suffering from mental illness, people with a substance use disorder, people with a disabling condition are going to have the hardest time seeking work or working to receive coverage. Also, people who have the longest gaps in their employment history or the least qualifications for employment that might have the hardest time finding work. A lot of that may come from complications from health conditions. Again, we've got this cycle that's going to only deepen. So as I said, instability, lack of social supports, crisis, homelessness are also increase the risk of misstep in navigating that bureaucracy. So if you don't know where you'll sleep each night and you also are required to report your frequency of looking for work in that time, you need to be showered every day to seek interviews, you need access to the internet, you need assistance. All of those things are made that much more difficult if you lack the stability or the foundation of having shelter and food supports necessary. Studies consistently find that these health problems, caregiving obligations, or instability are the most widespread challenges to overcoming the bureaucracy for social safety nets. So specifically the effective work requirements on Medicaid, among those who are not working in the U.S., about a third cite poor health as the reason. So we go back to the cycle. If you are required to work to get your coverage and you are unable to work because of poor health, you're stuck. About a fourth of those not working in the U.S. cite family responsibility. Again, programs like Medicaid or Social Security disability insurance are helping to cover caregiver costs as well, and people who can't work because they're caring for an ill family member are under the same burden of not being able to get their coverage if they can't work at the time. 1/5 cite school attendance. Again, this could be complicating some of, if you're attending school and unable to work, you might also not qualify for the Medicaid that you need for coverage until you're employed. So in theory, missed appointments or reports can be used for good as an excuse to continue to gain your coverage, but the burden of proof and the bureaucracy is, again, so prohibitive. We're looking at the same type of disproportionate sanctioning that keeps people out of work and is going to keep people out of receiving SNAP benefits or receiving Medicaid. Studies have also shown that the judgments for the validity of an applicant's request for individual waivers, so saying, I was looking for work, but I was unable to report that this week because my child was home sick with a fever, that those requests for individual waivers can be distorted by racial bias about work reports or work effort. And so this leads to a disproportionate sanctioning against African Americans. And we see that, again, as a most vulnerable population that's going to have a disproportionate, is going to be disproportionately impacted by these barriers. So the proposed changes to healthcare reform currently, the House bill offers states the ability to implement work requirements for people receiving Medicaid. In an attempt to roll back the expansion from the ACA or Obamacare, the bill will limit new enrollments into Medicaid based on expansion level requirements. So currently under the ACA, a person is automatically qualified for Medicaid if they make less than 138% of the poverty line in annual income. However, if we roll back expansion, we will go back to a situation in which Medicaid eligibility is based on disability or age, so elderly people are qualified for Medicaid. And so anyone moving forward won't be able to get into Medicaid unless they're grandfathered in current terms at 138% of the poverty line or meet the disability or age requirements moving forward. The other catch to that is if they are grandfathered in with a poverty level exclusion, they will have to maintain their Medicaid eligibility and their Medicaid enrollment consistently with no gaps in order to keep receiving Medicaid because of their poverty level qualifiers. So anyone who had a work requirement complication where they didn't submit a form, or they submitted a form incorrectly, or they had a bad 2 weeks of a flare-up of their illness and they were unable to look for work and then was expelled from the Medicaid rolls, would then no longer be grandfathered into the expansion definition and would lose their coverage again. So we're talking about a very precarious way to move forward, but really it's just an excuse to sort of clear the rolls as much as possible. So as we say, work requirements are a way to clear expanded Medicaid rolls and a way to clear any future Medicaid rolls by creating complicated and unnecessary requirements. So now we'll talk about cost sharing. Cost sharing is actually a typical component of health insurance. It can take the form of deductibles, co-insurance, or co-payments. Most of you who have private or employer-covered health care would be familiar with all different forms of these cost-sharing implementations, but some states have implemented low-threshold cost-sharing programs that require either relatively small premiums or copays or both for Medicaid. So these programs might only require that people pay $1 per month as a premium to have Medicaid coverage. But many people who need Medicaid don't have $1, or they might not on the day that the payment is due. This would then kick them off of Medicaid for anywhere, in terms of depending on the states, from 1 to 3 months. States take different tactics when people don't follow through as required. Some impose a coverage blackout that does not allow persons to regain coverage until they have paid or done what is required and the time required has elapsed. So we're talking about, if I simply can't make my $1 pay, it seems relatively low, it seems relatively simple, but if I can't make it on the day that it's due, it may be 6 months before I can regain coverage. Again, I would have to fill out all of the paperwork again, I would have to get into an appointment, get my transportation in line, and then have that dollar back ready again to pay at that time. So again, the most vulnerable are targeted by these programs. So arguments you'd hear on both sides, people who are for cost sharing in low-income programs say that it lowers overall spending by the government. I do have to say that if you imagine everyone who receives Medicaid paying $1, it seems to me like a silly argument. It shifts some costs from payers to enrollees, again, a very small number of dollars. It deters the use of specific services or perceived wasteful use of services. So this has more to do with copays or deductibles that you simply won't go like a kid in a candy store trying to receive all of the healthcare treatment you can if you have to pay a copayment or a deductible. And it encourages personal responsibility in healthcare decisions. Again, pretty similar to if I'm paying for part of it, I'm going to be more responsible. A con is that it increases the number of uninsured. Again, this is mostly just a bureaucratic sanction. It's going to make it difficult for people to comply at all times. And again, with the blackouts and the different rigmarole, it's significantly going to increase the number of uninsured. And studies have shown that the highest reduction is children from low-income families. So children can't fend for themselves, they can't get the coverage from themselves, but their parents are putting priorities of putting food on the table, putting shelter over the children's heads, and they might not make it to the appointment necessary to pay the dollar necessary to maintain the Medicaid and the CHIP benefits for their family, and might lose coverage for their families. So again, our most vulnerable are being targeted by these policies. Again, a con, copay and coinsurances decrease responsible use of preventative services. So we know that preventative services paying into regular checkups and regular treatment greatly reduce the cost of emergency care and catastrophic care. But if people are required to pay a copay or meet a deductible for those preventative care visits, they're much less likely to engage in preventative treatment or necessary mental health treatment until they've gotten to a problem that is severely exacerbated and requires more intense inpatient care, et cetera. So I would just point out that when we look at some of the lower spending by government and lower cost arguments, really that savings comes from decreased enrollment, not from people engaging in copayment. Medicaid, cost sharing on Medicaid, some states have already implemented such programs: Arkansas, Iowa, Indiana, Michigan. Studies have shown that these programs can lead up to 40 to 50% loss of coverage for Medicaid beneficiaries. Those who lost coverage because of the burden of cost sharing were more likely to have not received needed care in the previous 6 months, did not receive necessary prescriptions due to the cost of these drugs. 40% had an ED visit within 6 months of losing coverage, compared with 20% who did not leave because of cost sharing. 40% owed more than $500 in medical debt. We're the only advanced country in the world where medical bankruptcy is even an issue. And 20% were refused treatment because they owed money to a provider, which is really a significant challenge. So the proposed changes to our current healthcare system, the House bill offers states the ability to implement cost-sharing requirements for people receiving Medicaid. With the proposed cuts to Medicaid in the House bill and the President's budget cutting Medicaid as well, states are incentivized to implement such cost-sharing measures in order to reduce the number of people who are eligible, because they're simply not going to have the same amount of Medicaid dollars to spend moving forward. Finally, I just want to mention drug testing. It's important to note that drug testing is often used for safety net programs to decrease spending, incentivize abstinence, and mimic some work environments. It has been proven to keep people from applying for benefits, but there's no evidence that drug testing for benefits improves drug usage outcomes. So we're not incentivizing people to seek treatment. In fact, we're making it so that they're not getting the coverage that they need so that they cannot get treatment. There's not a current proposal to implement drug testing requirements for Medicaid, and it's not part of the House bill, although it's mentioned frequently in discussions in different states. But Wisconsin was planning to submit a waiver to CMS to include drug testing in their Medicaid treatment protocol, or Medicaid coverage protocol. Many people are seeking coverage from Medicaid so that they can enter drug and alcohol treatment. We're talking about needing Medicaid to cover drug use disorders, but not being able to gain it unless people can achieve abstinence. So we know Medicaid is one of the biggest drivers in the fight against opioid abuse and the opioid epidemic, and without its coverage, we're simply not going to be able to address the issue at a national scale. But I can't imagine telling someone who's finally ready to seek treatment to achieve sobriety through evidence-based means of treatment being told, but first you have to get clean to get your Medicaid coverage. And as I said, I'll go back to this slide just to close it out. There are a few other barriers that are important to note and understand that we're not going to discuss here this afternoon, but more frequent redetermination, so needing to check your eligibility for Medicaid. It's important that people don't have to go in monthly and get an appointment to check, or 6 months, every 6 months or every year. It should simply be that if your redetermination changes, that you would apply, or that you would address that. Lifetime limits on benefits. This is something that's huge in the House bill right now, that people who are seeking treatment for cancer frequently hit what a lifetime limit might be within a year of treatment, and then simply would not be eligible for health care coverage for the rest of their life, seemingly. So if they achieve remission and then need regular routine care or treatment for diabetes or treatment for complications from the chemotherapy that can often arise, they would simply be ineligible from having hit a lifetime limit. And I would urge you guys to notice that responsible reporting on this notes that this could affect even employer-sponsored plans. And finally, requiring payments to health savings accounts. Again, if we're talking about not being able to pay $1 in copayment or $1 in monthly premium, I can't imagine that being able to pay into a health savings account is not an incredibly restrictive requirement. We want to thank you so much for tuning in over the past 10 weeks to listen to 5 brief webinars on the different proposed changes to health reform in the U.S. I would urge you to check out any of our websites, endhomelessness.org, csh.org, I'm going to get these wrong, and then Google National Healthcare for the Homeless Council, and look for recordings of all 5 if you're interested in any of the other topics and any of the other ways that current legislative proposals may change or reform healthcare and the negative impacts that that could have on people experiencing homelessness or poverty. Thank you all again so much for tuning in, and please feel free to email me directly, nporter@naeh.org, if you have any questions about this topic or others. I think that's been said by Barbara DiPietro and Marcella McGuire as well in past panels, so we are open for questions if we can help. Thank you so much and have a great afternoon.